fibroareolar tissue. It sort of frames the opening of the nares. Yeah.
You said that that was the lateral alar cartilage. Where's the medial?
Well, this is lateral. What I'm suggesting in general, these are the lateral walls of the nares, and that would include this alar cartilage. Yeah. You don't always see this distinction. In fact, I've seen all of this in some texts called alar cartilage. And then we've seen this illustration or illustrations like this before. You're familiar with the relationship between the ethmoid from above, the vomer, very, very complex. Well, both of those bones have a rather complex configuration, and then the septal cartilage anteriorly. In the anatomical reductions, there is a traditional approach to describe the floor, roof, and walls of a structure. So in this slide, there's simply a description of the components of each of those. This is the nasal compartment here, of course, and what we're looking at, and this handsome fellow is are the conchae or the turbinates. And so, of course, the air is flowing over this conchae and turbinates via these openings. And in both courses, we'll talk a little bit about why that is important and necessary. And we'll talk about in here some of the relationships between this, between the meatus, between these openings and surrounding structures. I haven't adjusted the sound, so let's see how this.
In the next 3 sections, we'll look at the parts of the head and neck that are involved in 2 vital functions: breathing and eating and drinking. To get a preview of these major topics, we'll look at a specimen that's been divided in the midline. The passage for air and the passage for food and liquid begin separately at the nose and the mouth. Air passes backward through the nasal cavity and the nasopharynx. Food and liquid pass backward through the oral cavity. The 2 passages unite here. Air, food, and liquid all pass through this common passage, the oropharynx.
So that's kind of important. That's the confluence of the respiratory and GI pathways there at the oropharynx. Superior to the oropharynx, recall, is the nasopharynx. And this soft palate, at least superiorly, is the membranous system that separates them.
The 2 passages separate again here in the hypopharynx. Food and liquid pass backward into the esophagus on their way to the stomach. Air passes forward through the larynx and into the trachea on its way to the lungs. So the lines of travel for air and for food and liquid cross over in the oropharynx. It's important that air on the one hand and food and liquid on the other hand don't pass upward or downward into the wrong passage. To take care of this, there are important mobile structures above and below the oropharynx that act as separators. These are the soft palate above and the epiglottis and vocal cords below.
So these will be the structures that not only facilitate passage of air and ingesta, whatever's being masticated and then delivered to the esophagus, but these structures, of course, prevent air from entering the GI tract and from ingestion from entering the airways. So we mentioned the term turbinates. In general, the term turbinates is used interchangeably with conchae. There is a historical distinction, but for our purposes, it's not important. And what we're talking about here are these sort of bony projections. There are 3 bony projections that you can see there that form these ridges in the walls of the nasal cavity. There are 3: the superior, middle, and inferior turbinate. Notice the size relationship. The inferior turbinate is by far the largest. Superior is the smallest. In addition, there is the opening sort of inferior to and lateral to these. I mean, we don't see it here, but this opening continues on the underside of that turbinate. And at that point, there are frequent connections with adjacent sinuses. So what we're saying here is those paranasal sinuses that we looked at earlier frequently drain into the nasal passageways, as do, for example, as you can see here, the products of the lacrimal glands also drain into the sinus passageways. So it's no wonder that tearing or crying produces nasal symptoms. So I think this is the AP revealed image. This is of a cadaver, and you can see the middle and inferior conchae here. They've sort of taken away the superior, and we see some of what are called air cells. This is a very complex system of vacuities in the bone back there. And then again, you see the soft palate, the nasopharynx here, oropharynx here, and we're going to call this, he called it the hypopharynx, we're going to call it the laryngopharynx. They're pointing, the figure's pointing to these ethmoid cells, and there's also a label here called ethmoid bulla. A bulla anatomically is just a little hill or projection. And so that ethmoid bulla is the projection or prominence that overlies those ethmoid, usually called air cells, not hair cells, but air cells, AIR. There may be some hair cells back there too, especially when you get older. That's a joke. So be able to label the story. Because as far as I know, the only thing, Einstein argued there's nothing faster than the speed of light. I'm here to tell you that there is something faster than the speed of light, and it's the rate at which ear hair grows when you get old. So here's a conchae again. Be sure that you can identify these. I think we've talked about the anterior structures. You can see the nasal vestibule here, part of the nares. We've talked about the soft palate. Now, remember in our discussion of the oral cavity, we talked about some of the structures back in here that to contribute to the oropharyngeal isthmus. Well, superior to that, here's our soft palate. What we're looking at here is the opening of the eustachian tube. That's the opening of the eustachian tube, and you can see there's a sort of, I don't know, a sort of bony ridge or hill surrounding that. Yeah.
Yeah.
What problem do you have?
We don't have this slide.
Blank.
I'm not sure what you're saying. What?
One slide is a bunch of slides.
My guess here is that probably because the simultaneous demand on the server, I don't know. Oh.
I downloaded it last night.
Oh, it is? The only thing I can tell you, because we don't have time to do it now, is I'll repost them this afternoon. I didn't have time to check. Well, these aren't changed. They should be the same as. There's nothing to change here, so they should be working fine. I will download them and make sure that everything's working properly, but I'll do that this afternoon. So thank you for bringing that to my attention. I apologize. I haven't seen that before. I actually have some software. We had this problem one year for another reason. I bought some expensive software to address the issue, so if necessary, I'll use that. Right, so be able to name these structures. What I want you to be able to name again in a sagittal section like this are the components of the palate, the turbinates, the conchae. But as I was pointing out back here, you can see a little ridge surrounding that eustachian or pharyngotympanic tube. And that goes by a variety of names. The little medial ridge here is sometimes called the torus tubarius. And then remember we mentioned before that when you see this prefix, Salpingo, that's usually how it's pronounced, that refers to some type of opening. And so the Salpingo-Palatine fold is just describing a portion of this ridge. This is a term, it's a general anatomical prefix, suggesting that there's something in the neighborhood of or relating to an adjacent opening somewhere. In this case, the eustachian tube. So in the physiology, we'll talk about the importance, the physiological importance of these conchi for warming, filtering, and humidifying the air. We'll see why that's essential to the process of gas exchange, really facilitates gas exchange. In a figure like this, I think you can see I've have these structures numbered, so be able to identify the numbered structures here. You can see the frontal sinus, or at least a portion of the frontal sinus. This is a portion of the frontal brain, frontal lobes of the brain. This is the frontonasal duct. In this region, remember these sinuses are draining for the most part into the nasal passageways. You can see the ethmoid, or just a portion of the ethmoid bone there, that perpendicular plate. The nasal septum, we've already talked about the components of the nasal septum. The hard palate separating the nasal cavity from the buccal cavity, and then the rest of this would not be relevant. By the way, you'll notice there's an irregularity in the conformation of that septum. In this case, it's probably introduced by the sectioning of the cadaver here. But of course, you should appreciate that in reality, this is often the case, that one side of our nasal passageway is very different than the other side, both with respect to the size of the conchi and the symmetry of the septum. So you've seen this before. This just reminds you of the sinuses, be able to name them, be able to denominate the frontal sinuses. We talked about the ethmoid air cells down here, the maxillary. And of course, clinically, it's important to keep in mind that these can become infected and contribute to nasal symptoms because these sinuses drain into the nasal passageways. I think we have a small illustration of that. Yeah.
Would it be safe to say that ethmoid sinus is synonymous with the ethmoid air cells?
Yeah. The trouble is that, remember up there, I think back to that, the openings in various individuals can be of different sizes and descriptions. But what is always the case back in here is this bone it looks very, what's the word I'm looking for, spongy. And so those little pockets are just called air cells. They may be consolidated, they may not be. And again, you saw this one before, and you can sort of see in this picture the distribution and relative organization of these ethmoidal air cells. By the way, the passageways, they have a variety of terms. And again, I don't know what to tell you, except there's just no uniformity with respect to the anatomical lexicography. So there are the connections between the sinuses and the nasal cavity can be called ducts, D-U-C-T, not D-U-C-K, or ostia. Ostia is another term for opening. And we will encounter many ostias before we, ostium is singular, ostia is plural. We will encounter many ostia before we finish our discussion of anatomy. Here you can see sort of the appearance of this ethmoid and how you have this diffuse organization of vacuities and pockets and air chambers in there. Highly variable. And of course you ask yourself, why is it like that? Usual explanation, we talked about this before, to increase the likelihood of disease. No. But it often is the case, it does create problems, but probably for resonance. Vocal resonance is the usual explanation. But comes at a cost. And also to reduce the mass of the skull. See some of these openings here. It's palatine for artery primarily, but I think we have a better illustration of these openings behind or lateral to the turbinates. So here the conchae have been removed, and you can see, for example, the trajectory of the frontonasal duct connecting the frontal sinus here to the middle meatus. And by the way, over here you see a deviated nasal septum and how that falls out in this image, in this radiographic image. So you might ask yourself, would this person have symptoms? Would this result in chronic and persistent symptoms with respect to their ability to breathe, the flow of air one side relative to the other? So we mentioned the ethmoid bulla. This is the bulla here. Remember, the bulla overlies an aggregation of those air cells. This is simply illustrating the relationship between the conchae, the turbinate, and the bulla. And that structure can sometimes be occlusive, and therefore it can be surgically removed to enhance breathing. See an enlarged middle conchae down here. Let's look into the nose. Let's peer into the nose. Now notice at the end here, we're going to take the little scope and go into the nose. And so the MT is the middle turbinate, and then the LW is the lateral wall. And then the asterisk referred to an uncinate process. Uncinate, remember, is an anatomical term to describe hook shape. So what we're looking at is this thing right here, the uncinate process of the ethmoid bone in this video. So we're going in here, and immediately you should be able to identify the conchus and the meatus. So that would be the conchus there, the turbinate, lateral wall, and then that's the meatus there. The epithelium in this region, I think we've talked about it in the physio, or actually talked about it in here earlier. Most of this epithelium in that lines the upper respiratory passageway is ciliated pseudostratified columnar. This is even present in the mucosa overlying the conchae, and that mucosa, the thickness of the mucosa varies with a variety of stimuli, but it also responds to airflow, and the thickness can also respond to blood flow. So if the mucosa is a variable thickness based upon blood flow, it should not be surprising that there are any number of causes of nosebleeds, everything from dry, insufficient humidity in the air to some dysregulation of blood flow in this region. The olfactory segment, remember, is up there in the upper regions, up there by the frontal bone, the cribriform plate there by the cribriform plates in the ethmoid, but it's adjacent to the frontal bone there. Also has a ciliated pseudostratified columnar epithelium, but this epithelium is more specialized for the olfactory sensations. And then we've talked about the specialized bipolar cells and rifle cells that are present in that plate. And then in the physiology, we'll talk about the filtration functions and some other functions that occur in this region. Now, as I've indicated, bleeding is fairly common. You can see the profusion of blood vessels in this region. We've already talked about the greater palatine artery as we talked about the oral cavity. And then descending from above, you have a variety of these ethmoidal arteries, And we saw that large opening, remember that large opening we saw in the rear behind the middle turbinate there for the sphenopalatine artery. So all of those are coming into the septum and wall of the nasal cavity and creating this very dense anastomosing vascular system. And you can see right here, maybe it's worth noting this, writing this down. 90% of nosebleeds, which are called epistaxis, is plural, epistaxis is singular, occur in this region right in here, this anterior anastomosing network of vessels. Sometimes occur back here, but this is common because of the increased likelihood of desiccation. Desiccation is drying out. You have several illustrations of the same thing here. Again, this is Kieselbach's plexus here. So the nosebleeds are most likely to be anterior because of Kieselbach's, but occasionally you have bleeding into the throat because there's also the continuation of that dense network of vessels posteriorly. Again, the ethmoid, sphenopalatine, and palatine branches. I'm not sure that this is terribly important. We can see the proximity of the sphenoid sinus, which we've talked about. You can see the relative proximity of the maxillary nerve, and then you can see these alveolar nerves descending laterally. This is just to remind us of the location of the olfactory nerve, those bipolar cells. Just want to remind you where your smeller is. Your smeller, your ability to detect odors is not down here. It's up here. And that's a little surprising up there, just almost at the level of your eyes. Now, we don't think about autonomic innervation of the nasal cavity. The sympathetic activation primarily, this is our general rule, primarily influencing the size of the blood vessels. The sympathetic activation is involved in regulation of blood flow into this region. Whereas parasympathetic activation has more to do with the secretion of mucus. And of course, the two are quite related. If you're going to make mucus, you need more blood. All right, let's look briefly at the eye, the orbits around the eye. When we talk about is this one, when you looked at this, was this one also inaccessible? All right. I don't know. I can't imagine any circumstances unless there's an issue with the cervix. But these orbits, we're looking at them here. We've already looked a little bit at the bones that make up the orbits. You should, for example, already be able to tell me where the frontal bone is, where the lacrimal, the sphenoid, the maxilla, and so on. Be able to identify those, and those bones are listed here. We say that the orbit has a pyramidal shape. Pyramidal means along the lines of a pyramid, with the base of the pyramid anterior. So the pyramid is pointing back to where all the neurovascular structures, not all of them, most of the neurovascular structures enter the eye posteriorly. And then, of course, the eye is going to be positioned in that orbit, somewhat precariously, with all the associated musculature and vascular and neural structures. It's surrounded by an encasement of fatty tissue, adipose tissue. You ever do a cadaver dissection, you generally chip away the bone superiorly and then very, very delicately lift out all of the adipose tissue in order to access the underlying structures. We have previously looked at the superior and inferior orbital fissures and talked about some of the structures that pass through that region. So once again, this is just a nice summary of the bones. Be sure that you can identify all of the bones present. If you have to drag me out of the classroom, just please don't dishevel my clothing. So these bones are prone to a variety of fractures. We're going to talk a little bit about the fracturing that can occur in this region. Sometimes an object, usually rapid deceleration on a hard object, but the fractures may or may not damage the eye, but you can see the whole possible spectrum of possibilities here. There can be transverse fractures involving the entire interior of the skull, or you have sometimes what is called a blowout fracture, where an object just strikes a single orbit and causes comminution at the perimeter of the orbit. And of course, attending that to one degree or another may be damage to the eye itself, or just as likely, there may be mechanical entrapment of the muscles or the nerves present in the eye. And part of your job is to diagnose how much of those structures are actually involved. So you can look at the little figure over here, and your first task is to find the elephants. Can you find the elephants? Yep. Yeah. The elephants of Rogers and the lions of Dolenz. The lions of Dolenz are labeled 1, 2, and 3. So those are the lions of Dolenz. And the lions of Dolenz make up the little elephants of Rogers. And these are the structures. These are the edges, if you will, the perimeters that are most likely to be affected in a traumatic injury, independent of any additional. What we're looking at here, yeah, this is the blowout type fracture I was talking about. There's a baseball coming in there, and that's never good. There are also a series of what are called the fork fractures, and there are all kinds of these. There are 3 different major categories. But in general, what is implied by a fork fracture is that there may be a fracture across the 2 orbits of the eyes. There may be a transverse fracture below the piriform aperture there, below the nose, or any combination thereof. Sometimes you encounter fractures, again, sort of going up like this and then coming down on the other side. So all of those would be termed the fork fractures. That would be one of the examples there. See a little different. Yeah. Ruin anybody's day.
I don't care who you are.
All right, let's talk a little bit about the eye. Some of these initial illustrations, we have better illustrations or more detailed illustrations we'll look at. But in general, the eye opening itself is called a fissure. This is true for many of the anterior openings. The fissure, the eyelashes, properly here termed cilia. You'll notice at the apices of the fissure are the lateral and medial canthus. Lateral canthus here, medial canthus here. We'll find that the lacrimal gland is up here. It releases the tears that hopefully flow across the surface of the eye to aggregate at the lacrimal lake and caruncle. I've always wanted to laugh or chuckle when I hear that term, but it's caruncle. And then here's the inferior lacrimal papilla. Remember, we indicated previously that there's a passageway between the eye, the tears of the eye, and the nose. So that's the function of that little punctum papilla there. Oops. Yeah, we'll have a better illustration of the tarsus, so let's not read about that too much. There's a distinction between the two major classes of gland up here, the tarsal gland and the glands of the eyelashes. We'll have a better illustration of that in just a moment. Inflammation of the eyelash glands, the cilia, is called a stye. Inflammation of the lid, more approximately the lid, is called a chalazion. And we'll look at examples of those. Remember, with the musculature, the orbicularis oculi consists of two components. There's a circumferential orbital part, that's the part out here, and then you have a palpable part, palpable, that actually extends down into the eyelids. So this is the palpable part here. This is the orbital part out here. But that all is part of one muscle. And orbital there, palpable there. And then this would be, again, we've indicated the fissure. So we're looking up here at the tarsus. As I said, I think we have a better illustration of this. I'm not sure that I like this picture because we really have to disarticulate a number of very intricately interwoven structures in the eyelid. The eyelid is rather more complicated than you might imagine. But you'll notice that there's an overlying muscle here called the levator palpebrae superioris. And that muscle tissue then is going to extend down to the upper lid. But both lids then have these tarsus or tarsal plates extending into them. We begin to see in some of these illustrations some of the critical structures. So now we're looking at the components of the components extending into the eyelid. Here's the palpebrae superioris muscle again. Here's a portion of the tarsus, again sort of circumferential. This is the superior. This is the inferior tarsus. Notice again at the fissural angles or the fissural apices, we have the two ligaments, the lateral palpable ligament and the medial palpable ligament. And then over on the right, you begin to see some of the complexity. Again, I have a better illustration coming up because this is a bit oversimplified as well. But notice again, this is the levator muscle here and its tendon. And then exterior to that would be the palpable component of the orbicularis. So this is the palpable orbicularis, and this is the levator. And then here you have the cilia. We've already defined ptosis. And then we have, as I say, a better illustration of the tarsus muscle. But by the way, remember when we talked about Horner syndrome? You get about 20% loss of ability to open the eye. It's the tarsus muscle that is influenced or innervated by the sympathetic division. The blood supply to the orbit is primarily achieved by the ophthalmic artery and its branches. We've already talked about some of these, the supratrochlear, supraorbital. The ophthalmic artery, please note, is a branch of the internal carotid. And the angular artery, not the angular vein, but the angular artery is the terminus of the facial artery, which you should know quite thoroughly by now. So you can remember that external carotid eventually winds up the skull here, becomes the superficial temporal. So you can see the superficial temporal laterally. And then you can see the transverse facial. We talked about that before. Remember, that's going to be superior to the maxillary, all contributing to perfusion of these tissues. And then here's that angular component, which is the terminal artery of the facial. Both the interior of your eyelid and the surface of the eye, the surface of the white portion of the eye here, are covered by conjunctiva. So we want to sort out the components of the conjunctiva. The conjunctiva is sort of a membranous tissue, membranous protective tissue that, for example, prevents your contacts from ending up back there in your brain. There's a little membrane, a little reflection of the tissue here. So let's look at this. Remember, the conjunctiva is not present around the visual portion of the eye, but extends from this portion on down, then reflects onto the lid. So let's look at this. The region where, or the termination of the conjunctiva proximal to the pupil is termed the limbus. And it simply joins the conjunctiva and the cornea. The portion of the conjunctiva overlying the white tissue you see here, the sclera, is the bulbar conjunctiva. And then you remember our definition of reflection. Reflection is simply an abrupt folding of a tissue back on itself, or you can do that anatomically. This reflection of the conjunctiva down here between the eyelid and the cornea is called the forniceel conjunctiva. And then finally, this portion of the conjunctiva that lines the interior of the lid is called the tarsal conjunctiva. And then sometimes you see reference to a marginal conjunctiva at the perimeter of the lid. Notice the yeah.
Sorry, I was just wondering about the punctums before you were going.
Yeah, the punctum, we'll talk about just a moment, but that has more to do with the dissipation of tears. So there's a little illustration coming up on that. Yeah.
The forniceel is there a palpebral conjunctiva that consists of forniceel and tarsal?
Palpebral. So the palpebral is going to be deep inside here. We're superficial to the palpebral. All this is a effectively translucent or transparent tissue that extends from here all the way down to here, then folds back. There's a terminus right here, it just reflects, and then covers the interior of the eyelid. And so that forniceel is the reflection. That's where it's folding from the eye onto the lid. Right? If you had your contact lens, the contact lens is not going to get past the forniceel conjunctiva.
And the tarsal conjunctiva is different from the palpebral?
Yeah, the palpebral. So when you talk about the palpebral, I'm not sure exactly. That's going to be deep to these structures. I'm not sure what you're talking about. The ligament, again, all of these structures that we're describing as palpebral are deep to the conjunctiva. The conjunctiva is superficial, so maybe I'm not understanding the question.
Okay, I'm not asking right.
In any case, notice the nature of the epithelium here. It's non-keratinized, stratified columnar, and includes the goblet cells, which you know secrete the mucus. And in fact, there are multiple glands for secreting. I guess the better way of putting this, there are multiple glands at the periphery of the eye opening to increase the viscosity, to increase the thickness of the fluid that is used to protect and bathe the eye. And that fluid serves a variety of functions, again, mechanically protective, immunologically protective, and perhaps acts as a lubricant as well. So there's reference to the punctum a moment ago. Here, I just wanted to, more fundamentally, make sure you understand the relationship between the lacrimal gland of the eye, which is upper and outer here. And so that gland is going to release the fluid, the tears, that then are going to suffuse. The anteriors are going to sort of move in this direction just by the hydraulic gradient. And then be taken in to this apparatus here. Probably that's as good an illustration as any. This is called the lacrimal sac, the lacrimal canaliculi. And then you can see inferior to that, the canaliculus, is the nasolacrimal duct. And it's that nasolacrimal duct then that went into the into the nasal passageways. So the gland is up here, going to move across the eye. Here's our sac, canaliculates, sac and canaliculates. The duct then conveys the tears again into the nasal cavity. Adjacent to the inferior conchus, remember the inferior is the large one.
So starting at the duct down inferiorly, that would be all considered apparatus.
Yeah, the trouble is, I've never seen any, if you're asking about the difference between the sac, and the duct, I've seen the terms used interchangeably. I guess you would say the sac is the superior terminus up here by the little canals, and then everything inferior to that would be the duct. But ultimately, all of this duct is going, as you can see, pass through the bone and empty the tears into the inferior megatus then. Seems like there's one other thing I wanted to point out here. Yes, here it is. I just wanted to make sure you saw the location of the lacrimal papilla and the punctum right here. So again, the gland in this position, and then all of this apparatus sort of diametrically opposed to that on the medial side. Was there a question? All right, so here's where things are a little complicated. So why don't we take a break and look at the organization of the eyelid in a little more detail.